So we are ready to move on to talk about penicillins, which really are that ideal group of antibiotics. They really are drugs that are going to inhibit the bacterial cell wall. Make sure that you use your notes that I have provided for you as well. So as we move on to begin to look at this particular group, we focus on kind of the origins of penicillin. So interesting enough, Dr. Alexander Fleming, and you may really know this from your microbiology class, this guy really is the one who stumbled on penicillin. He had apparently been on a vacation and returned to his lab and noticed that in some of his petri dishes, there were colonies of Staphylococcus aureus that were contaminated with some mold called penicillin. And when he started looking at these under the microscope to examine what he found, he saw that the penicillin was actually preventing the growth of the pathogen Staphylococci. So that's really how he came upon the idea, or really the creation of penicillin. And he really is noted for the quote that says, "One sometimes finds what one is not looking for. When I woke up just after dawn on September 28th, 1928, I certainly didn't plan to revolutionize all medicine by discovering the world's first antibiotic or a bacterial killer. But I guess that was exactly what I did." So it's an interesting quote from him. So who knows really what you one day are going to stumble upon and how you might impact the world in which you live. So really never underestimate your abilities and what you can do. So as we begin with our discussion of penicillins, we really have to remember that this particular group of anti-infectives are very subjective to bacterial resistance. In other words, while they were once the ideal drug and were used for multiple infections and were quite effective in treating those infections, we now know today that penicillins are not nearly as effective because bacteria are resistant or can develop some resistance to the penicillins. And there really are only three ways that the bacteria sort of put up a barrier to penicillins. One is they keep penicillins from actually reaching their target molecules. So sometimes bacteria will camouflage their receptor site so that penicillin doesn't know where to go. Number two, penicillins are often inactivated by bacteria because the bacteria produce enzymes that break apart the penicillin and render it ineffective. We talked a little bit about penicillinase, word that I introduced in class the other day. There's also a word that we use called beta-lactamase that are chemicals that will inactivate the penicillins from being effective. And the third thing is that bacteria produce something called a penicillin binding protein, but those penicillin binding proteins, or the PBPs, have a low affinity for the penicillins. So there's not great binding of the drug to the protein, and therefore the protein cannot get into the bacteria. So the drug cannot get into the bacteria and destroy the cell wall. So really, those are the three ways that we think about penicillins becoming or their resistance to certain bacteria and making them ineffective. So it'll be good for you to try to think about these three factors and really understand them in terms of what they really mean and why those are important factors about how bacteria work with penicillin. So certainly read in your book about how penicillins are resistant, or how bacteria are resistant to penicillins, and that'll be something good for you to be familiar with in the upcoming exam. So penicillins cannot reach their targets very frequently. So we're going to talk about this a bit more. So this is gram-positive and gram-negative bacteria that I introduced this week. But if you'll notice that in gram-positive bacteria, we have a very thick cell wall and then the cell membrane. But when we come over and look at the gram-negative bacteria and compare them, we see that there are actually 3 layers in gram-negative bacteria that we have to get through to get inside. So there's a cell membrane, there's a cell wall, and then another outer membrane. So because of these 3 layers, gram-negative bacteria really create quite a barrier for the penicillins to get through. So we find that many of the penicillins are not very effective against gram-negative microbes. Only certain penicillins, like ampicillins that we talk about and think about, can penetrate through those 3 layers. So that's really kind of an important concept to think about. And again, with where we once had an ideal drug to treat infections, but now we have this particular incidence and worsening aspect of gram-negative bacteria that cause such a significant problem for bacteria, such a significant problem for penicillins or any antibiotics to get through. So I really wanted to talk again about these terms called beta-lactamases. This term beta-lactamases or beta-lactamase is another term. These are enzymes that really are going to cleave to the beta-lactam ring of the penicillins, and some other antibiotics have beta-lactam ring on them to make them effective. But these enzymes will prevent or eat or destroy that compound that will cause these antibiotics to be ineffective. So beta-lactamases are really selective to specifically penicillins, and those are really, and really a term that you could use interchangeably is penicillinase. So both gram-positive and gram-negative bacteria can make those penicillinases, and those really genes that code for beta-lactamases really are located on the chromosomes and the plasmids that we talked a little bit about in class the other day. When we think about the plasmids, again, remember those plasmids are the double-stranded compounds and components within the cells of the bacteria that help with the genetic altering and alterations of the bacteria and help the bacteria to become smarter and evade some of the antibiotics in order to increase their resistance to certain drugs. And I show this with the conjugation approach. And beta-lactamases are the enzymes that are going to bind to or cleave the beta-lactam ring on certain antibiotics to prevent them or render them to be ineffective. They cannot then, once that inactivity occurs, they cannot kill the bacteria from there. We talked a little bit about these penicillin binding proteins, the PBPs that occur. So the problem is really that bacteria produce these and they have a low affinity for penicillin and all the other beta-lactam antibiotics, so that the penicillin cannot travel into the bacteria and be effective any longer. We see that this is really true with MRSA or methicillin-resistant Staphylococcus aureus. Can be pretty significant disease-causing organism. We'll talk about MRSA a little later as well. So let's talk about this group of drugs called penicillins, which really were the ideal antibiotic, and now know that we have some significant problems with resistance development, and I talked about resistance this past week. But when we talk about these penicillins as a group, basically these drugs are relatively safe. They're very infrequently cause any kind of toxicity. They're safe to give to children, older adults, and even to people who are pregnant. The penicillins really do have a beta-lactam ring in their structure that gives them their name as the beta-lactam antibiotics. So all beta-lactam antibiotics have the same mechanism of action. And when you think about that mechanism of action, we really have to understand how penicillins and other beta-lactam antibiotics do their job. They disrupt the bacterial cell wall and really prevent the synthesis of the cell wall. So they bind to the cell wall and they destroy it. So they prevent the cell wall from forming and building up. So that's really a very important way that that penicillins work. And this is really essential that you remember how penicillins work in this aspect. It's also important to note that penicillins are not going to go through the blood-brain barrier except for when the meninges, and then remember the meninges are what covers the brain. When they're inflamed or the patient is febrile, then penicillins can cross or pass through the blood-brain barrier and have an effect at that point. And it's really not going to occur unless there's some type of meningitis or fever from occurring. So if someone has meningitis, then we could use penicillins to treat those patients. Now, when we talk about penicillins, we have to remember that there are 4 different classifications of penicillins. So there are narrow spectrum penicillins, that what this really means is like penicillin G, penicillin V, these are penicillinase sensitive, so that means that they can be broken apart and rendered ineffective. But now a second category is narrow spectrum penicillins. These are penicillinase resistance, and these are stronger. These are more tolerant of the penicillinase. So nafcillin, oxacillin, and dicoxicillin are the narrow spectrum penicillins here. So the next category is broad spectrum penicillins. Almost everybody's had, or at least heard of, amoxicillin and ampicillin, which are penicillinase resistant at all. They can't, the penicillinase is not going to impact that. However, in the next category, we see extended spectrum penicillins, which are anti-pseudomonal penicillins, and the one that we tend to think of or use in this category is piperacillin. So those very difficult bacteria to kill, the Pseudomonas, is important to have an antibiotic so that we can treat those significant infections. So those are the penicillins that you're really going to want to become familiar with and be able and familiar with the categories that they're in, and then understand kind of the purposes and uses for each of those. So table 84.1 on page 1032 is a good table to look at for this as well. So why do we use penicillins? What are their indications for? So active against some gram-positive cocci and bacilli. So what we're really talking about disease states like streptococcus pneumonia or meningitis, or streptococcus viridans, which could cause some infective endocarditis and lodges in the heart and cause some infections in the inside of the heart. Or we have some pharyngitis that can occur with streptococcus pygenes. So certainly Neisseria can lead to meningitis, and then we have some other sexually transmitted diseases that can be treated with penicillins, and those are spirochetes, things like syphilis and gonorrhea. So when we think of some of the narrow spectrum penicillins, specifically penicillin G, we're really looking at kind of the first penicillin that was available that really was good for gram-positive streptococci and also good for Neisseria as well. Remember, that causes meningitis. So we see that penicillin G can also treat certain anaerobic bacteria and spirochetes, as I said. So these really are narrow spectrum antibiotics, and these are the categories that are least toxic of all antibiotics and among the safest of those medications. So some of these disorders are described here for you as well. So here's some disorders that you may see penicillin G used for. So pharyngitis, endocarditis, gas, gangrene, some of those sexually transmitted diseases, you'll find that penicillin G comes in different preparations, or it may come in with some type of potassium mixture or procaine or benzathine mixtures. The procaine and benzathine mixtures are given IM, and these two combinations of medications are given with penicillin G to decrease the pain. And if you've really had any kind of penicillin G administered intramuscularly, it can be really uncomfortable. So all forms of this penicillin can be given IM, and sodium and potassium penicillin G can be given IV as well. So really, penicillin G really cannot be given by mouth at all because of the unstableness of it in the stomach. So the hydrochloric acid of the stomach will destroy the penicillins. And again, we talk about the procaine and benzathine preparations, and really these are going to slow down the absorption of the medication, and this is another depot medication that could be slowly absorbed over time. So this is why, when we're treating certain infections, then we can give them IVs, IM, so that they can be taken over a course of time. And the penicillin G with procaine or benzathine are not able to be administered IV. And this is a picture of you here that shows some meningococcal septicemia by Neisseria that can cause some significant problems for people. Additionally, we have beta hemolytic strep, beta hemolytic group A beta hemolytic strep that can cause initially a really bad strep throat that can lead to abscesses. And when this particular pathogen gets into the skin, it can lead to necrotizing fasciitis. And this is really the flesh-eating bacteria that you hear about. And this is an example and picture of it. But interestingly enough, you really think about the group A beta hemolytic strep can actually be transported to the skin and the surrounding structures with a very small injury. Sometimes with a rosebush prick can cause some significant infections to develop. So as soon as something like that happens, you have to encourage the patient to wash the environment and clean it as rapidly as possible. So we'll talk about now this penicillin V and penicillin K, which really are stable in the stomach acid. And these are very similar to penicillin G. However, these medications, again, are very stable in the oral form so that it can be taken by mouth for outpatient monitoring. But these must be given with medications. The medications must be given with meals. And again, the penicillinase resistant penicillins are potentially narrow spectrum in nature, and they are really, with their narrow spectrum, they have an ability to, again, resist the penicillinase, and that they can now start resisting that penicillinase. So now we start having some emergence of methicillin-resistant Staphylococcus aureus, or MRSA, that really can become resistant to these medications. So if we have a patient that has MRSA, we're not going to be effective and not be able to treat patients with nafcillin, oxacillin, or doxacillin, or dicoxacillin. We also have a broad spectrum antibiotic, which these are aminopenicillins. Aminopenicillins are the aminopenicillins are ampicillin and amoxicillin. They have the same spectrum as penicillin G, but they have the ability to cross over those three layers of the gram-negative cell wall. Now, we refer to that as the gram-negative cell envelope, but these medications, ampicillin and amoxicillin, can treat then both gram-negative and gram-positive organisms. So we'll see that amoxicillin is treated very commonly for sinus or ear infections. There are also some other pathogens that we can use the aminopenicillins to treat: Haemophilus, E. coli, Salmonella, and Shigella. These are medications that can be used to treat these situations. So it's important to remember that both these broad spectrum antibiotics, the aminopenicillins, are rendered inactive by the beta lactamases. So they're not really active then against organisms like Staph aureus. When we give these medications, we have to think about some of the potential side effects or allergic reactions. So amoxicillin and ampicillin, we have to watch for rashes and diarrhea. Really, diarrhea less so with amoxicillin than ampicillin, but we have to be very cautious and watch for those potential negative outcomes. So there's another medication that we call augmentin, which is really in a situation where we're adding clavulanic acid to the amoxicillin, that we are making it more effective because that clavulanic acid inhibits the bacterial beta lactamases. So it's like we're giving amoxicillin like a whole new set of armor for amoxicillin to be used against the bacteria, because we now have this beefed up, stronger amoxicillin with clavulanic acid. So the same thing is true with sulbactam, which can be added to ampicillin to create the drug Unison. And again, this sulbactam inhibits the bacterial beta lactamase. So this is really important to know, because when we see medications like clavulanic acid and sulbactam added to an antibiotic, we need to understand why we are augmenting the original penicillin in treating and the bacterolactamases. So let's now talk about the extended spectrum penicillin, which is piperacillin. There's only one in this category, and you'll see the trade name for piperacillin is Zosyn, but this particular penicillin is going to be effective against several different kinds of pathogens, but it can also be very effective against Pseudomonas, some Enterobacter species, Proteus, certain Klebsiella as well. So there's a wide range of pathogens that this will impact. So again, we will see this medication piperacillin with a medication called tazobactam. That's just like the clavulanic acid and the sulbactam. They inhibit the beta lactamase that's created by the bacteria. So when we add those, again, this tazobactam together to the penicillin, we see Zosyn, and we see a much more extended spectrum and a much more broad spectrum, broadly extended penicillin. So very frequently you will see patients for this empiric broad spectrum antibiotics, Zosyn will be added on a Q6 hour dosing, Q8 hour dosing, and then we will see some kind of gram positive coverage as well. When you really combine the beta lactamase inhibitors with the penicillins, you're going to be able to then extend them. So again, the three different kind of beta lactamases that we're going to use are sulbactam, tazobactam, and clavulanic acid. So be mindful of when we're having patients on those medications like amoxicillin or Unison or Zosyn. Those are actually combinations of penicillins with a beta lactamase component. So we really need to talk briefly about the adverse effects that occur with penicillin. So this actually is a great picture that shows an urticarial rash that is very, very itchy, and sometimes we can even see patients with some significant flushing or diaphoresis, palpitations, fever, arthralgias. We see people who are arthralgic have joint pain, and people who have myalgias have muscle pain, and sometimes we can even see people having respiratory distress to penicillins. Typically, though, people are going to have an allergy. It's typically going to start within the first half hour. However, you can have an accelerated reaction up to 72 hours later, and sometimes we don't even have reactions until days or even weeks later. So really, let's talk again about anaphylactic shock. what does it really mean? So we know that some people have some severe allergies to penicillins, and they can go into an anaphylactic shock or some kind of severe respiratory distress that occurs. Why does this occur? Because the airways then are constricting in those patients because of the huge reaction to the penicillin. So we have a massive release of penicillins, and we have a massive release of what substance? It's histamine. So when histamine is released, it causes massive vasodilation that leads to hypotension. The patient becomes tachycardic and an inability to try to overcome that hypotension. And people develop cyanosis typically around their oral airways or their mouth and their conjunctiva and potentially in their nail beds as well, that are significant for patients. Very frequently, patients will then go to convulsions or become unconsciousness, and those anaphylactic shock treatment is going to be typically used with a Benadryl or type antihistamine type response, some H2 blockers or Pepcid. They're going to decrease the histamine release as well. Yes, it is used for H2 blocking acid release in the stomach, but it's also used for histamine release blocking as well. And frequently we're going to have people end up with some type of corticosteroid added as well to their regimen. So again, if people have anaphylactic shock to a medication, not just penicillins, any kind of medication, obviously supporting their airway, monitoring their blood pressure, administering epinephrine is going to be very important, as well as this antihistamine that we talk about as well. So it's also important to talk about penicillins that can have serum sickness. So penicillin serum sickness usually develops about 7 to 21 days after the treatment. So with this, you have to be careful in that we may miss this and this is not really an allergic reaction, but it's maybe confuses that. But we see signs and symptoms of penicillin serum sickness as fever, arthritis, rashes, itching. But we also see this enlarged lymph nodes or generalized edema, which we really don't see with an allergic reaction. So typically how this is treated is pain medications, antipyretics. We will typically give Tylenol or NSAIDs or a steroid or something like that to treat it. So other side effects of penicillins, we may see neurotoxicity, which is toxicity to the central nervous system. We may see some seizures or confusions. Lots of times people develop hallucinations as well. If we are giving a patient medication, penicillin G with potassium component, then we have to worry about hyperkalemia as well. So we obviously have to monitor their cardiac status and their potassium levels so that we don't get too high of a potassium level. So certainly we have to monitor their kidneys and for any kind of renal impairment. So we have to monitor their I's and O's as well as their other kidney markers. So we need to think about some interactions with penicillin. So probenecid is a medication that's used to treat gout. So it really delays the excretion of penicillin, and it hangs on to penicillin. The body will hang on to penicillin longer. So sometimes we will see an elevated and potential toxicity of penicillin if we don't be careful. So sometimes, adding some probenecid to penicillin, then we will see that the lower dose of penicillin is needed. So we also see that we cannot mix penicillin with any kind of aminoglycoside. So some examples of aminoglycosides are gentamicin or tobramycin. If we put those two together in an IV medication, it will render those they will cause crystals to develop in the line, and they will be inhibited from either one of their being effective. So if we're giving tetracycline as well, it's potentially leads to bactericidal effects of penicillin. So really it's most effective when bacteria are rapidly growing. So when we think about MRSA, methicillin resistant, so when we know that when this organism is transmitted via direct contact between people and objects. We also know that Staphylococcus aureus produces this beta-lactamase enzyme that causes the bacteria to be very resistant to penicillins. So we know that because, or in 1960s, really, whenever we looked at methicillin was developed to be used to treat Staph aureus, we all know that penicillin-resistant Staph aureus developed by the 1970s. There was significant impact of MRSA in the community and really in the sick patient. So we now know that actually there's nobody even getting methicillin anymore at all. So we know now that that vancomycin will treat MRSA, but now we're starting to develop some vancomycin-resistant Staph aureus as well. So we know that we have to be cautious and careful with patients who have an MRSA and under treatment. So we have to be very careful that we are washing our hands, cleaning equipment between patients. And we now know that 75 to 78% of Staph aureus is isolated in lab cultures that are totally resistant to methicillin. And we don't even use methicillin anymore. So when we talk about MRSA, it really can begin as a small site on the skin that potentially could develop a significant abscess on the site. At the site of injury. Sometimes we have surgical sites that are infected with MRSA, and those wounds very rapidly worsen that potentially can have some systemic infections as well. So huge risk for wrestlers as well because of the exposure for MRSA on the sweaty mats. So be careful when you're at the gym that you are wiping down the gym equipment and we're not having exposure to MRSA. Maybe you have a small scratch on your skin or something. We know that we can get some significant infections with that. So there's a page 1032 in our book that's important to look at as well. So let's revisit then. So we talked about bacteria being able to produce these penicillin-binding proteins. I just want to reevaluate and re-talk about this. And so penicillins have to bind to proteins on the cell wall to be able to enter the bacteria. Some of those bacteria produce penicillin-binding proteins that have a low affinity for penicillins or don't want to bind with the penicillins, and very frequently with other beta-lactam antibiotics. So if the penicillins can't bind to the cell wall, then they can't get into the cell. So MRSA works this way, and the penicillins have to be able to bind, again, to the cell wall in order to penetrate the bacterial cell wall in order to be effective.